Welcome to the session, Guidelines in Cancer-Associated Thrombosis. We'll be using CAT for shorthand because 3 words that are long and complicated sometimes. It is my honor to chair the session, which boasts 2 great speakers who over the next half hour, each maybe 20 minutes for each talk and 5 minutes for a chat after that, will steer us through the maze of what we know about CAT. I'm hoping they'll show us that the guidelines are useful, but they are actually pretty narrow, and possibly highlight where we don't know things and how we should go about trying to find out more. The session, like I said, is going to be 2 20-minute talks. We're going to give 5 minutes after each speaker for specific questions for that talk, and then we're going to have a 10-minute panel discussion at the end. You're all encouraged to send or through the chat facility on Zoom your questions. I'll pick them up and I'll try to answer most of them, all of them hopefully, but if we do run out of time, we'll answer as many as we can. So our first speaker is Dr. Raza Alikhan. He's a consultant hematologist at the Haemophilia and Thrombosis Center of the University of Hospital of Wales. Raz has extensive experience in clinical research in thrombosis, and he's been UK chief investigator for the Mariner study and the Caravaggio study, which is a big study in cancer-associated thrombosis. He's published extensively in the field of thrombosis and hemostasis, and he currently chairs the British Society of Hematology Writing Group for CAT. So I can't think of anyone better versed to give us an update of the existing international guidelines in the treatment of CAT. So Raz, you have 20 minutes. If you can share your screen and you can set off.
Okay, firstly, Anthony, Prof, thank you very much for the introduction, and thank you to Joe and all our colleagues for arranging National Thrombosis Week. I've had the privilege of presenting earlier in the week and dialing into some presentations. They've been excellent. It's been a great meeting, and so I'm also in very esteemed company with my 2 professorial colleagues, both of whom are actually sitting on the British Society for Haematology CAT Guideline Committee. So it's going to be interesting how we're going to present some evidence for guidelines, and then I think Simon will show how limited they are, and we'll have a discussion, and then we're meeting in a couple of weeks to write a new guideline. So it'll all be very interesting. So anyway, I shall start off with my disclosures, and then we'll just sort of set the scene from an epidemiological perspective. And it's of no surprise to our audience how important thrombosis is and venous thrombosis is, not only in the UK but across Europe and globally. It's an important cause of both morbidity and mortality in both cancer patients and non-cancer patients, and it's one of the reasons I actually became a haematologist, to try and improve how we manage patients with thrombosis, developing new anticoagulants, safer treatments, and improving diagnostic pathways. So if we think of our population in the UK, for an adult, your prevalence in the UK is about 1 chance in 1,000 that you will have a venous thrombotic event. If you have cancer, that risk goes up significantly. It's at least 5-fold higher. So, you know, I was doing a clinic earlier on this morning, talking to a patient who was asking me, why did I get a cancer? And one of the things, why did I get a thrombotic event? And one of the first things we were just discussing was how her risk had gone up just from her diagnosis and the prothrombotic action of her cancer. The other thing to consider is that for patients who present out of the blue with proximal DVTs, PEs, unexpected venous thrombotic events, 1 in 10, maybe 1 in 20 patients are diagnosed now with a cancer within 12 months of presenting. And so the thrombotic event is actually the presenting feature of their cancer. When we compare our cancer patients with thrombosis to those that don't have cancer, our patients with cancer-associated thrombosis, or CAT, are more likely to have recurrences while on treatment, but they're also more likely to bleed when we anticoagulate them. So they're at a higher risk of getting a clot, they're more likely to have a recurrence, and then they're more likely to bleed when we treat them. And different types of cancers have different risks, and we may discuss this during today's meeting, but there are certain sites that are more prothrombotic, and patients are more prone to developing thrombotic events associated with their cancers. And then finally, it's really important to acknowledge that aside from the patient's cancer itself, infections and thrombotic events are important predictors of a patient's mortality if they occur during cancer treatment. And so for our patients who get CAP, they're already being discriminated against in terms of their potential outcomes from both a morbidity perspective in terms of recurrences and bleeding, but also potentially from a mortality perspective. Now, there are many reasons why this may occur. So we touched on the different sites of cancer that are prothrombotic, but we may also look to the right upper quadrant here. The patient's treatment is important. Simon and I do an MDT once a week where we discuss many different types of cancers and presentations. And there are certain things that come up very regularly. We look after breast cancer patients who are on FET chemotherapy, and we very classically see that FET chemotherapy causing thrombophlebitis. But I'll work with my myeloma colleagues and they'll be managing patients with IMiDs, and we'll know that the immune modulators are having a prothrombotic effect. But both Anthony and Simon will manage patients who have been on cisplatin or platinum-based drugs, and we know different agents can be prothrombotic. So again, the conversation I was having with my patient earlier on this morning, not only was it explaining to the patient that he'd had cancer, but he'd also had a surgical procedure to remove the cancer, and he was now on a platinum-based drug. And so we'd had a sort of perfect storm of risk factors coming together, and he'd had a femoral DVT which needed treatment. And so there are many things that come into play in terms of why our patients develop cancer-associated thrombosis. And the age of the patient is also important. I touched on the fact that the prevalence is about 1 in 1,000. This is for your adult population, but as you age, your risk just from age goes up over time, such that if it's 1 in 1,000 when you're 40, it might be 1 in 100 when you're 80. So you double the patient's age, but you increase the risk of thrombosis some tenfold. And then if you add in cancer, and we've used this sort of description of the sort of thrombotic potential and the burden that the sort of threshold that you need to get over, I think with patients with cancer, they already start at a much higher potential, and they've already cleared some of the hurdles. And so on the left-hand side is where I sort of look after patients at diagnosis, hospitalization and treatment. And as the patient's treatment and they respond, their risks go down, but then they relapse, and Simon and Anthony will be looking after patients who progress with recurrences and then obviously come to palliative care. And so your risks change over time. And where I'm going to be talking about treatment and guidelines, very much on the left-hand side of this presentation, the acute presentation, the acute diagnosis of cancer-associated thrombosis. And so that takes me nicely into what the evidence base is. And we've been using low molecular weight heparin now for 20, 30 years, the gold standard treatment. So this is a summary of 5 studies that were done with enoxaparin, dalteparin, and tinzaparin. And just to orientate you, you have the actual rates in numbers in terms of events and the total number of patients within that. The statistics are presented in terms of your risk ratio, and then we have this dot and whisker plot where the line of unity is at 1. On the left-hand side, we're favoring low molecular weight heparin. On the right-hand side, we're favoring essentially warfarin with a low molecular weight heparin lead-in. And you see that when you look at reducing the risk of recurrence, all of the point estimates are on the left-hand side. The confidence intervals generally cross over, except in the clot study with dalteparin. And as a whole, we reduce the risk of recurrence with low molecular weight heparin by about 40 or 50% when compared to warfarin. Now, many people think that we use low molecular weight heparin because it's safer. However, if you compare the historical studies with low molecular weight heparin versus warfarin, actually the risks of bleeding are very similar. And so the key really, and the reason we've been using low molecular weight heparin, is that the risk of recurrence is low rather than the risk of bleeding is low. So that's the evidence for low molecular weight heparin. Now, this is a patient I've looked after in clinic. He's come to us with his acute femoral DVT, underlying malignancy, and we've told him that he needs to start our gold standard treatment, which is dalteparin. And so we show him the syringe and we teach him to inject, and we give him his first course of treatment, which is 30 days at full dose. And then he comes back and then we step him down and we give him another 6 months of treatment. And before you know it, these injections start adding up. And if you're just injecting either side of the belly button, you start running out of space very quickly. So this is another patient. This is a patient that many of you will have seen previously. You can almost see where, well, in fact, you can see exactly where he's been putting his syringes in. And so for our patients, we advise them to use the entire abdominal space. Don't just go either side of the abdomen. We talk to them about rotating injection sites, and I classically talk to patients about injecting and trying to create a smiley face. And I think if you look very carefully, you can almost see the smiley face there on his abdomen. But the key here is he's got this other space, this fertile virgin space above his belly button. So not only do we suggest a smiley face, but I like the patients to rotate the injection sites and use a sad face and go round, or use a clock face. Keep going round. Now that's great if you've got some space, and this chap's got a little bit of space to inject into. But this is another patient from clinic, and you can see there is no room there for a smiley or a sad face. He's got to localize where he gives his injections. And so this is a huge problem for patients in terms of finding areas that they're not bruising, that they're not tender. The other thing to take into account is that when we look at prescribing and persistence with anticoagulation, remember for CAT, we're looking at treating patients for 6 months. When we try and treat patients and we compare low molecular weight heparin to oral anticoagulants, so warfarin, or in this case, rivaroxaban, you see that after 6 months, so the red line there is low molecular weight heparin, maybe half of the patients in this particular study had sort of fallen off in terms of taking their low molecular weight heparin. There's far higher persistence with oral anticoagulation compared to injectables, even though the evidence shows that the injectables are better than warfarin. There's persistence, particularly in this example that I've shared with you. And what about the DOACs? So historically, we've been using these now for quite a while, up some 5-6 years for some of us. The registration studies, the phase 3 studies, more than 30,000 patients were randomized, and yet less than 5% of the patients that went into those studies had cancer. And the type of patients that went into those studies with cancer, these were not the type of cancer patients that we're managing in our clinics. These were well-controlled, low-risk patients. So what is the evidence for direct oral anticoagulants? So there are 4 randomized controlled trials. I'm not going to talk about the Adams study because this is essentially a bleed study, and I think there's a bit of bias in that. So I'm going to just present the results for 3 studies, for rivaroxaban Select-D, for edoxaban Hokusai, and for Apixaban Caravaggio. And all of these studies are compared against the gold standard treatment, which is dalteparin. So patients get 200 units per kilo for 30 days. They then step down to 150 units per kilo for 5 months. And so all of these trials compare against the same standard low molecular weight heparin. So in Hokusai, patients were randomized, 1,000 patients were randomized in a 1-to-1 fashion against dalteparin or edoxaban. And for edoxaban, you need to have a lead-in of at least 5 days of low molecular weight heparin, and then edoxaban for the majority of patients at a dose of 60 milligrams daily, but a step down to 30 if you weighed less than 30 or you had renal impairment below 50. And this study looked at both bleeding and risk of recurrence and put them together as a composite endpoint, and said that there was no difference between edoxaban and dalteparin in terms of the composite endpoint. But if you break down events, what you actually see is that with the DOAC, with edoxaban compared to standard care dalteparin, there's a significant, there's a reduction, there's a trend towards less events. But when you look at bleeding, you see a trend towards more bleeding with edoxaban. So that's the trade-off, and that's how they get to this sort of status quo. And most of the bleeds in this edoxaban study were GI bleeds. These were patients with luminal GI cancers, and they were bleeding from those sites. Whereas if you take that out, I think the bleed rates come down. So that's Edoxaban. Then Apixaban, same sort of study, more than 1,000 patients, 1-to-1, standard of care versus Apixaban, 10 BD for 5 days, and then for 7 days, and then you step down to 5 BD for 6 months. And as we see with the Edoxaban hockey size study, there is a reduction in events when you compare Apixaban to dalteparin. But in this study, not the same rates of bleeding. There's no trend towards more bleeding. And then finally, we look at dalteparin compared to rivaroxaban in the SELECT-D study. So again, a 1-to-1 ratio, about 400 patients. Patients in the rivaroxaban arm get 15 milligrams twice a day for 3 weeks, and then step down to 20 milligrams daily for the 5 and a bit months. And similarly, a significant reduction in event rates in terms of recurrences, but a trade-off in terms of more bleeding with rivaroxaban. And as we saw with Edoxaban, this was driven a lot by GI bleeding. And actually there was a protocol amendment during the study to stop recruiting patients with GI cancers. And then that brings the bleed rates down. So that's the evidence for DOACs. I know there are 4 RCTs, but really, in my opinion, there's 3 RCTs. And so this morning, I just had a quick look at the literature. There are almost 6,000 papers on how to treat cancer-associated thrombosis. There are 3 RCTs of DOACs. And as of this morning, there are 15 meta-analyses and systematic reviews of those 3 anticoagulants to tell you how they work against low molecular weight heparin. It's mind-numbingly, you'd expect it to be the other way around. So based on all of that, 3 studies, 15 meta-analyses and systematic reviews. And I'm just throwing in that there's another one in there. There's my abstract from ISTH last year. So I'm just as much to blame as anybody else. We're all doing it. We're all doing meta-analyses on these 3 studies. Okay. So what do the guidelines say? Well, 2015 BSH, these are out of date, and that's why Anthony and Simon and the BSH will be updating this when we meet very soon. But it was quite forward-looking in that, despite the fact that we hadn't done any RCTs with direct oral anticoagulants, the guideline committee 6 years ago was already pushing itself towards offering oral anticoagulants unspecified as an alternative to low molecular weight heparin. And the guys on that committee knew exactly what they were writing when they wrote oral anticoagulants. They didn't specify DOACs, but or they were called NOACs at that time. So that was very interesting. That's 6 years ago when we had no evidence for the use of DOACs in CAT. And then Simon and his colleagues on the ISTH panel made some very useful recommendations a couple of years back. And essentially, for patients presenting with an acute VT associated with a cancer, a low risk of bleeding, no interactions with systemic chemotherapy, they looked at the evidence and suggested that Edoxaban and rivaroxaban were an option or an acceptable alternative to low molecular weight heparin. I like that. And then we have the NCCN recommendations. These are a little bit more confusing, particularly as they have both dalteparin and enoxaparin in them, although they acknowledge that the evidence for enoxaparin is lower. They also put in, for the monotherapy arms, rivaroxaban and fondaparinux. The fondaparinux evidence, I would suggest, is even lower. And then for the combination therapy, again, they go with Edoxaban, but somewhat strange, on the right-hand side, they also put dabigatran in there. There are no RCTs of dabigatran, and less than 4% of patients in the RECOVER studies, the 2 RECOVER studies, actually had cancer. And so I really don't think there's very much in the way of evidence that we can talk about for dabigatran currently. ASCO then, very similar. Low molecular weight heparin or fondaparinux, or low molecular weight heparin plus Edoxaban. No mention then again of Apixaban. I think the timing of the publications didn't fit in with the Caravaggio results. And then last year, we have the NICE guidelines, which touch on CAT. And they touch on CAT in that they suggest you consider a DOAC. And if the patient is unsuitable for a DOAC, you consider a low molecular weight heparin. And if the patient is unsuitable for a DOAC or unsuitable for low molecular weight heparin and warfarin, only then do you consider low molecular weight heparin? And then they throw in a little curveball at the bottom, is that they mention also that most anticoagulants do not have a marketing authorization for the treatment of DVT and PE. And in fact, from a low molecular weight heparin perspective, I think it's dalteparin and tinzaparin that have approval. And yet in my place of work, we'll often use enoxaparin, but clearly that's not approved. I think rivaroxaban has approval, and the wording in the SPCs for edoxaban and apixaban need to be updated, because they still suggest that there is no evidence to support the use in CAT, even though both of those drugs have been studied in these big RCTs with more than 1,000 patients. And then finally, the most up-to-date guideline published a couple of months ago by my colleague and his colleagues. They recommend low molecular weight heparin over unfractionated heparin. They suggest apixaban, edoxaban, or rivaroxaban over low molecular weight heparin. And I think this is important, and this is where it's really important that we work together, because while the recommendations are to treat patients for at least 6 months, we are in a very evidence-free zone as to what to do for patients. And my conversations with patients this morning in clinic about going beyond 6 months have been very limited by, or have been affected by the limited amount of evidence that there is to guide us beyond 6 months. But the most recent guidelines suggest a DOAC over low molecular weight heparin. Okay, so that is a whistle-stop tour through CAT, morbidity, mortality, the trials, and the recommendations, and apologies for trying to squeeze that into 20 minutes. Thank you.
Thank you much for that, Raz, and thanks for keeping to the 20 minutes, even if you squeezed a bit towards the end. I don't seem to have any questions here, unless Joe has one. So I'll ask you myself one then, just maybe to get the ball rolling. Do you think that the excess GI bleeding is a class effect, or is apixaban really a different drug?
Yeah, it's an interesting question. I think we've seen it in the AF studies, and we've seen it in the non-malignancy VTE studies. We have seen trends. I think if you do meta-analyses and you bring all of the DOACs together, what we see as a class is less intracranial bleeding, at least 50% less. And as a class, we see a trend towards more GI bleeding compared to low molecular weight heparin and warfarin. With apixaban, there does appear to be less GI bleeding in the VTE and AF studies that we've looked at. And as I mentioned with the rivaroxaban, the SELECT-D study, there was a protocol amendment to stop recruiting GI patients. In Caravaggio, there was an active, ongoing, keep recruiting patients with GI tumors to see if there is a GI signal. Having said that, when Simon and I manage patients with GI tumors, we expect them to bleed no matter what anticoagulant you offer them. And so putting a patient on low molecular weight heparin with a GI tumor, I would still not be surprised with an active GI tumor to see bleeding. And so we tend to still manage, Simon and I would still tend to manage these patients with low molecular weight heparin, just based on the current advice and evidence, rather than putting in apixaban. I wouldn't have the confidence to do that at the moment.
Okay, you've covered one of the questions, although they do ask about urological cancers. So yes, the GU or the luminal story is becoming one. Do you want to make a comment on that?
Yeah, I think Simon and I both at the moment, like I say, we have the luxury of an MDT where we discuss these cases weekly, and we don't use DOACs at present for patients with luminal tumours. So that does include the GU patients as well. I don't know, Simon, if you want to jump in there and give your perspective, particularly from the guidelines perspective.
I mean, I think we have to be pragmatic here. And if you've got someone with a fresh clot, which is unstable, I want to make sure the anticoagulation is optimal so that we can stabilize that clot and make sure there's minimal risk of that clot propagating. And so, if for the first month we go in with a low molecular weight heparin, I think that is a small cost on the patient having to have the injection before we then try them on a DOAC if we think that's okay. From my perspective, it's better to get that clot treated properly at the beginning and then later on we could consider going to a DOAC, and if there's bleeding, maybe we can lower the dose of the DOAC, certainly at the 6-month point. But I don't think we can be messing around with suboptimal anticoagulation in the first, in the first 6 weeks. That's, that's where the risk of the clot propagating is going to be greater. Some of my GP friends actually think that a DOAC is a wonderful way of diagnosing a bladder cancer in their AF patients, that the first sign that they'll have of a bladder cancer is they start bleeding on the DOAC. And so I don't think we can underappreciate that this is a real issue. And it's also a big concern to the patients as well.
Okay, we're getting some questions here, so I'm going to continue with the questions, Simon, a bit, because I think we've got a couple of good ones. One for you, actually. The question is, where does preference come into this?
I think we're in a situation now where we're individualizing anti-cancer therapies based on molecular genetic abnormalities, and that's how kind of precision-based, patient-centered, individualized medicine is getting. And so therefore I think we should discuss options with patients, but we also do have a duty to explain to them our rationale. So for example, previously, when we didn't have DOACs as an option, the most important thing for compliance was to actually explain to people why we're using low molecular weight heparin, why it's important to comply. And when they understand those things, they will often go with it. It's how we sell this to them. And if I'm discussing a DOAC, I will already be going in having pre-assessed the risks, if there's a risk of bleeding or if there's a risk of drug-drug interaction. So I don't think it's ethical to offer someone a choice when actually they can't have one of those choices. But I will certainly, if I feel it is safe and efficacious for them to have either a DOAC or a low molecular weight heparin, I will discuss that with them and what's most important. And what's actually quite interesting is not all patients opt for the DOAC.
Okay, wow, we're getting a bunch of questions, but they all seem to be problematic ones. Let's see where the guidelines are not good enough, and then we'll try answering some of these questions. Okay, so, it's what can I say? It's my real pleasure to introduce Simon Noble, who's the Marie Curie Professor of Supportive and Palliative Medicine in Cardiff University. He's currently, I think, the Medical Director of Thrombosis UK. Is that Wales, Simon, or are you Thrombosis UK?
I don't think it really matters.
Okay. And you're a medical advisor to Anticoagulation UK, but you've also been involved in, writing guidance for the NICE, at least, maybe not the last ones, but also ASH. But I think your major contribution to this field has been giving the patient's voice. And I think that's a major element of what was missing from most of the old guidelines. And it's a pleasure to see now that the patient is identified as someone who has got a stake in this problem. And I think your Pelican studies, and we won't have much of that today, I don't think, are milestone studies. And you've also studied, of course, the impact of CAT in the palliative care patients. And I was seeing there was a question from the audience that we'll deal with in the hidden study in the hospice setting. So I think you're uniquely placed to discuss with us today the gaps in the evidence and tell us where we go from here. Thank you, Simon.
Okay, thank you, Anthony, for that very kind introduction. Always a pleasure to be working with you. Raz, thank you for that excellent talk. So I've had a rough few days, so I'm in a bad mood. So I hope this doesn't colour my talk too much. But one of the things that really made me particularly cross was getting a referral of a 91-year-old who was admitted with anemia, breathlessness and anemia, hemoglobin of 60, and the team had found that she had a isolated subsegmental PE. So they'd topped her up with blood and started her on low molecular weight heparin, proudly telling me that they were using low molecular weight heparin because it's in the guidelines and would I see them. And I think one of the problems sometimes is that people become so guideline focused that they stop actually looking at the patient and stop even using their brains. And I think this is actually one of the downsides of guidelines. And I believe that when we work on the BSH guidelines, Anthony, Raz, and those other colleagues who are going to be involved, I think we mustn't lose sight of where the data isn't helpful. And Armand Trousseau's done many wonderful things, but I actually love this quote of his, which says, every science touches art at some points. Every art has its scientific side. The worst man of science is he or she who is never an artist, and the worst artist is he or she who is never a person of science. And I think sometimes one of the problems with guidelines are excellent. Guidelines show us what the strength of the data is, but they've almost taken on a cult-like status where every patient, if the data doesn't exist, they can't make a recommendation. And we're even getting to a point now where there is almost this purity in guideline production, such that clinicians may have limited involvement in making the decisions, and certainly wouldn't be allowed to make a vote on something if there was any perceived conflict of interest. And I think this is a real weakness, because we actually need to know what we don't know. Copernicus, to know what we know and what we know, and to know what we do not know, and what we do not know, that is true knowledge. And the problem with the guidelines is they're only saying where we've got the data, and basically if there hasn't been an RCT, the guideline can't happen. Fortunately, the studies do include patients with metastatic disease, so that's good news, because the majority of the patients that we see in our CAT service, myself, Raz, and Nikki Pease, I think we see about probably 400 to 500 new cases a year. So the studies did include people with METs, performance status 0 to 2, although those with performance status 2 were fewer than far between. Had to be an estimated prognosis of greater than 3 months, and I can promise you that is not the population I'm always seeing. Platelet counts above 75,000, weight above 40 kilos, and they had no active bleeding. I think these are the places where we've really got the limited data. Certainly with respect to the DOACs, the people with central venous catheters, upper limb thromboses did not get into these studies. Patients with thromboses in strange or non-regular places, your thrombosis in your splanchnic vein, or your vena cava, or your renal vein, etc. Patients of poor performance status. The limited data of primary and secondary brain tumors as well. Whilst they were allowed in some of these studies, the numbers who are actually recruited are pretty much too small to make much of. And I think this is the big one we really don't have decent data on yet, is actually what we should do beyond 6 months. And just about every guideline I've read has had the kind of cadge of, you need to weigh up bleeding risk, thrombotic risk, patient preference. And yet all of those are very difficult to quantify, especially, whether there's what the bleeding risk is, what the thrombotic risk is. And also because these are things which will change over time. And finally, the thing that we really haven't got our heads around yet is clinical decision making. How should we present the data to our patients to make a shared decision? Or even how should we approach the data that is there with respect to what we should do? If you look at the recommendations, I was looking through the recommendations of the ASH guidelines, which I was a co-author on. If ever anyone wanted to blame me for the ASH guidelines, I wouldn't get upset at them, because it's such a rigid process that you actually have very little kind of input. The data takes itself where it goes. But you look at the majority of the recommendations, it's deciding what drug to use. So we've made the assumption we're going to treat the clot, and it's basically, what do we use in the first few days, what do we use in the next few months, and what do we use long term? And that's what takes up most of it. And actually, how many guidelines do we need? Raza's actually said, yeah, there's been 15 meta-analyses alone for DOACs. Now, what on earth is the Prospero registry for if it wasn't to actually register you were doing a meta-analysis to prevent it happening? How many man-hours, how many thousands of pounds, dollars, euros has been spent on staff time doing exactly the same piece of work? And what's interesting is if you look, these are a few of my patients I see. So, you know, this is an old boy who's got plenty of comorbidities, ECOG performance status 3 going on 4, and he has renal impairment. Here's one of my patients who has got a large clot in his femoral vein, and he's got a melanoma from which he is bleeding. And here's one of my patients waiting for a platelet transfusion because he's got 0 platelets. My colleague had thought it couldn't possibly be a DVT because the platelets were too low. Anyway, we in the if I were to look at the guidelines and see what we should do about this, pretty much they're not going to help. They're not going to tell me what to do in those because we don't have the RCTs. And so if you don't have the data, the guidelines don't actually really tell you much. To do this, the best you can do is get opinion pieces and consensus. And that's what was written. We're talking about 8 years ago. And with the exception of thrombocytopenia, I don't think those guidelines have really changed that much because the data hasn't changed. If we just look at the inclusion-exclusion criteria, we can see that they are pretty similar. So patients with a life expectancy of greater than 3 months, or if it's less than 3 months, they're not getting in the studies. Performance status 3 to 4, renal impairment, liver disease. And yet these are people that we see all the time. A lot of the questions we'd be thinking about, especially with the patients of poor performance status, is, well, you know, can't we just extrapolate the data? We know from, say, clot and catch, you know, we use these, the low molecular weight heparins quite nicely in patients with these various factors that prohibited them from getting into the studies. But with the exception of Caravaggio, what you find is that the populations are actually getting sicker, are getting better prognosis than in the early studies. If I just kind of go back on this, if you look, so you look at 6-month mortality, clot 40% dead within 6 months, whilst here, you know, it's much less. Metastatic disease, similar. Performance status of 2 rather than 1 or 0. Once again, this is a fitter population. And how many having systemic therapies? Smaller number again. So overall, we are looking at the DOAC studies are representing a fitter population than the clot studies did. So this is fine if you want to treat the Stepford wives, and we just treat a bunch of patients who are all 70 kilos, platelets of 160, creatinine clearance of 60, no bleeding risk, and they're on a drug which doesn't interact with anything. And the guidelines are absolutely fantastic. But it's actually all the other patients that I see in my practice. And when I had a look at my last clinic, I think I saw that probably about 70% of the patients would have been excluded from these studies. So I just want to show a bit of data about 2 key areas which I think the guidelines are not that helpful with. I think one of them is brain tumors, and I think we always worry about that. The majority of the work has been done by Jeff Zwicker, doing a meta-analysis, which overall would show that the bleeding, there is an increased bleeding rate with primary and secondary brain tumors. But if you have a look here, it tends to be far more prevalent in the glioblastomas. And actually, you know, there's some studies would even show a bleeding risk of up to 20%. And the rate is worse on anticoagulation. Whilst when you look at the studies looking at metastatic disease in the brain, the rate of bleeding appears to be no different if you are or are not anticoagulated. And although the numbers are small, if you were to look at the more vascular tumours, so I'm thinking of the melanoma brain mets, renal tumour, testicular tumour brain mets, even then there didn't appear to be a greater bleeding risk. Recently, a paper in Blood Advances in which they looked at patients who had been anticoagulated either with low molecular weight heparin or DOACs. It's a retrospective study, and it showed that over time the risk of intracranial hemorrhage was not different statistically, be it through a DOAC or low molecular weight heparin. It looks like the major intracranial hemorrhage rate in the low molecular weight heparin is higher, but actually statistically this did not reach significance. The one thing I am glad about, and you know, this did appear in the ASH guidelines, was to talk about patients' values and preferences. And I think we have to realize that these values and preferences may change over time. What concerns them initially may not concern them later. Patients who are resistant to injections at the beginning may get used to them. Patients who are worried about bleeding early on may not worry about it later. And or, you know, clots, their attitude to clots may vary. So in the same way that when we're looking at managing anticoagulation, we should be reviewing a lot, we should also be reviewing where the patient is at with this. And my suspicion is that over time, what we're going to find is, rather than there being this one size fit all of this is the drug we're going to use and you stay on it, I think it is going to be something which we look at and will change. There'll be time when they're on a low molecular weight heparin, then they'll be on a DOAC for a while. And this will vary according to what therapies they're having and, you know, what they feel about the anticoagulant. Something I think we're still looking and learning about really is the true impact of drug-drug interactions, particularly P-glycoprotein and CYP3A4. You know, we are warned about them, but actually how much in reality and in practice do these drugs affect anticoagulation? From my own clinical practice, I do find that patients who've been on a steady dose of DOAC, when introduced to dexamethasone, for example, I've seen quite a few cases of breakthrough or recurrent thrombosis. I think it's just something to keep one's eye on. But I think the other area I just want to cover very quickly in the last 5-10 minutes, because this encompasses all of the challenges that we see in lots of different patients, is the palliative care patient. I mean, how we define a palliative care patient is very much, you know, variable. But what we would say is that as malignant disease progresses, as you get more advanced cancer, the risk of thrombosis goes up. So does the risk of bleeding. These patients often have many comorbidities or on other drugs as well, worsening renal and hepatic function, poorer absorption of oral drugs. Let's not forget, when your albumin plummets through your boots, it's not just your ankles and your sacrum that's going to become edematous. You'll also see that the bowel, the villi, which are there to maximize intestinal absorption, become very thick and boggy. Drugs aren't always absorbed as well. Multiple pharmacology with drug-drug interaction potential. But I think the final thing is that when we're looking at patients with advanced cancer, and we're looking at what a patient's desires are, we may be focusing more on symptom control rather than just extending life. And that's just endoscopy to show, capsule endoscopy to demonstrate that here you have all the villi for absorption. Here you have very edematous bowel, so you won't get such good GI absorption there. The studies which we have done do not represent the needs of a palliative care patient. So we've had to rely largely on observational data with a focus on quality of life, symptom control, and prolongation of survival is not the aim. So what I would say is, when I'm dealing with a palliative care patient, either someone who is a palliative care patient who gets a clot, or if I have a patient who is entering the last weeks of life, you've got to make judgment calls, and the guidelines don't tell you this. You've got to treat the patient, not the scan. If I get called about a palliative care patient who has got a clot, which they found on the scan, my first question is, why did we do the scan? You know, don't do the scan if you're not going to act on it. But actually, what are we trying to achieve here by anticoagulating? I do not agree with the nihilistic view of a large PE is a nice way to go. I can challenge that with all sorts of evidence. But I think everything we do has to be there to focus on optimizing quality of life. Now, I think we need to make an evaluation within the context of their cancer journey. Are they receiving ongoing systemic anti-cancer therapies to prolong life? And I think if they are, and that has been appropriate, I think it's appropriate to treat the clots, because those clots will be a result of the systemic anti-cancer therapies. But if they're only receiving symptom control only medicines, and we're thinking about introducing an anticoagulant which may increase the risk of bleeding, an anticoagulant which may accumulate because of renal or hepatic impairment, I may even question actually what symptoms do they have, and can we control them other ways? And I think, in the last few weeks of life, rather than all the usual reasons that we want to treat a cancer-associated thrombosis, I think so long as we look at treatment of symptoms and quality of life, I think our plans become clearer. Which anticoagulants? Well, if I were to make one generalization, I think if I am using an anticoagulant in an area where the evidence is lacking, my default is a low molecular weight heparin. That's because I have less concern about drug-drug interactions. I can modify the dose. I can monitor an anti-10A level. And so I think we can vary it a little bit. We've got strong data to say warfarin is not a good drug in the advanced cancer patients, even if you have regular INRs, increased bleeding, drug-drug interactions. Also, we know that with low molecular weight heparin, the absorption is going to be less of a problem. Yes, DOACs have the luxury of the oral route, but only if we can be certain it's going to get in, and then when it does, it's not going to accumulate in a population who we've already said are at a higher risk of bleeding. I think this is one of those things that, to a hammer, everything is a nail. And one of my hematologists said to me, to a hematologist, every clot is to be anticoagulated, because that's what you're used to doing. You're faced with a clot, and how do I treat it? But there's going to come a time where I think we should also think about, when do you stop your anticoagulants in an advanced cancer patient? There was a study across 22 palliative care units in France, which showed that there was a clinically relevant bleeding rate of 9.8%. And that was most marked in patients who were on anticoagulants, either anticoagulant prophylaxis, on anticoagulant therapy, cancer patients, and people who've had previous surgery or bleeding. And what they did see is that these patients, even when off anticoagulation, had a high risk of bleeding, but that went up even more if they were on an anticoagulant, be it primary prophylaxis or treatment. Now, finally, what I would do is share with you data that we collected from our CAT clinic, where we looked at the long-term outcomes of over 440 patients. And of those around 200 who died, we looked at how long anticoagulation was kept going for, where they died, and if they had any complications. And what we found was that well over 50% of patients continued anticoagulation until the end of life. And in the last week of life, there was a bleeding rate which was significant enough to make it into the notes, because this was a retrospective study, to say that 7% of patients had a clinically relevant bleed. Now, I believe that at end of life, symptoms attributable to DVT or PE can be managed with end of life medicines. And it would make sense to me that as people enter the end of life, the anticoagulants are stopped. So finally, to conclude, there are currently 15 meta-analyses for DOACs and CAT. There are zillions for low molecular weight heparin in CAT. and the guidelines are only going to be as good as the data we have. So I think when it comes to the BSH guidelines, we've got a bit of work cut out for ourselves, because you know, what we don't want to do is produce a document which is identical to all the other documents which different professional organizations have done. I think we need to have something which has got some clinical practicalities as well, where we can say where the data is weak. But, you know, if you've got expert opinion there and people who've got day-to-day clinical experience of this, you can at least have some input into what you would think is the best thing to do. Thank you.
Thank you, Simon. It's a great talk. Much food for thought there, really. We've got questions. Some of them I think you've sort of answered, but there are some very interesting questions that I think I'll open it to the panel straight. I don't think we need to give specific 5 minutes, because I think we only got about 10 minutes. So let's go for that. So again, going to the 6-month story, you've got a really fit patient and they get to the 6 months, but they still got an active cancer. The question here is, would you reduce the DOAC dose at that point in time if you got them on a DOAC? For example, Apixaban from, I don't know, 5 mg BD down to 2.5 mg BD, or really down to 10.
Do you want that? Do you want that, Raz, or shall I do that?
Simon,
one?
yeah, go for it.
Yeah.
Okay.
Yeah, you go, Simon, and I'll jump in.
Yeah. So the answer is yes, I would use a DOAC, and I'd use a DOAC at a lower dose. Our current poison of choice is Apixaban, and I would go in at a lower dose. The reason being that it is licensed for the secondary prophylaxis beyond 6 months. I think the most important thing here is to acknowledge that Isabelle Meyer and colleagues in France are leading the international study APICAT, which is looking to answer the question of whether or not 2.5 mg BD or 5 mg BD of Apixaban would be best for secondary prophylaxis. I think you're leading that for the UK, Anthony, and I think it's an absolutely vital study.
Thank you, Sam, for that. Raz, do you want to add anything to that?
Yeah, I think I'm going to put my guideline cat hat on and evidence base and say, so Hokusai went out to a year on treatment dose. Select D had the option of 20 and 10. Caravaggio stopped at 6 at 5 BD, and APICAT's the one that's going to answer the questions, because it's randomizing patients to 5 BD versus 2.5 BD. But as Simon rightly says, we both discuss patients regularly, and we reduce the dose currently to 2.5 BD and follow these patients up as well. So while we're waiting for your evidence, Anthony, our practice is to reduce the dose.
If I could just say one other thing, Anthony, I mean, having kind of reflected on these talks, if there's one learning point I would really urge people to consider is having a CAT MDT of some sort. I think the benefit of myself, Nikki and Raz discussing each case is not only educational, it means that we reach a consensus of what is best for that patient, or what to present to that patient. We don't always agree, but we always talk it through. And, you know, it's absolutely fantastic. And it really means that you're not there doing this on your own. You're actually able to get a decent consensus of opinion, which also in the areas where there are zones of indeterminate practice, I think that supports us as well from a medical legal perspective.
Great. I mean, you've got a luxury, Simon, so I'm jealous. Raz, this one's for you, and it's a good question actually, because it's going to come up. Do you think there are possibilities that we may have better agents in the pipeline, ones with less bleeding?
Yeah, so I can't talk too much, but we're looking at a direct factor 11 inhibitor, particularly in CAT patients. We're in discussion about that. So if anybody's interested in participating in a phase 2/phase 3, email me, and Andy Cohen at King's is another point of reference. But yeah, I think there are some very interesting molecules. The ideal goal for me as a hematologist is an anticoagulant that doesn't cause bleeding. And Simon, when I first started working with him, I anticoagulated anything and everything, unless there was an absolute contraindication. And I've learned heaps from Simon and Nikki in palliative care in terms of there is a time to stop. And I think Emma G's asked that question about when you should stop. And Simon, I think you're probably the best person to answer that.
Yeah, I think actually Ander is putting out feelers, and there's 2 studies, one particularly in the GI patients, very interesting. So if anybody listening and they're interested, Ander Cohen is your port of entry. Another very good question here, and again, I'll put it to you, Raz. If you've got somebody with impairment of the GI tract, do you use a different DOAC if they've had, let's say, upper GI surgery, or a different one if they've had, let's say, the whole bowel taken out with a bit of the small bowel? Can you use a DOAC?
Yeah, that's really interesting, because you absorb from the stomach and the proximal small bowel, the jejunum. You mentioned Andy Cohen. He's done some interesting work for patients who've had gastrectomy, and shows that if you don't have that bit of bowel, you absorb later on. We haven't touched on measuring levels, but I think that is one occasion when measuring absorption by measuring a DOAC level is useful. Even if you don't have access to that at your center, I think that's one where I would send a sample away to show that you're absorbing it later on in the bowel to confirm. But yeah, we certainly use it in gastrectomy patients.
I've got a question there myself. What would you use there? Would you use a trough level or a peak level?
Yeah, so I would actually do both. Firstly, I would do a 2 or 3 hours after an oral dose, show that you're absorbing and see how much you're absorbing, because there's quite a wide range, and then see how much is left. If you're twice a day Apixaban, I'd measure it 12 hours. If I was on Rivaroxaban or Doxaban, I'd do it 24 hours to see that we've still got some measurable drug. Because you may absorb a small amount and be therapeutic, but by 12 or 24 hours, there's nothing left because you didn't absorb enough. So I think a peak and trough for me in a patient that's got.
So would you keep the same regular peak and trough, because you've probably got a different transit in the gut there? So is this empirical, or you're giving us some recommendation?
Yes, so that is a practice-based recommendation, not an evidence-based recommendation.
Excellent. BSH guidelines, here we come. Okay, I think I've got just one more question. I mean, does the MDT or the delivery have to be physician-led only?
No, and it's only because the funding of these posts, we would love to have the prescribing pharmacist there. We would love to have a specialist CNS there as well. Nothing would make us happier. Unfortunately, I am yet to perfect the art of bum alchemy, which means pooing out gold. And until I do, I can't afford to pay for these people who would be absolutely essential. I would say that there are other models of practice. So in Swansea, there is a pharmacist, Kieran Walsh, who leads on this and runs an excellent service. But, you know, he is far more bound within the guidelines and the prescribing details. And since I would suggest at least 30% of our patients exist outside of the guidelines, you need to have someone who's able to prescribe for those. Because the thing is, you know, it doesn't matter what the guidelines say, the patients who have a clot and were excluded from these studies don't have the luxury of not being given the drugs because they don't apply to the prescribing of them. We've got to actually still prescribe. So I think you do need a medic there who has an interest, but I think pharmacists, nurses would bring so much depth and richness to this that, you know, the reason we don't have it is not by choice at all. It would make it a fantastic
Thank you, Simon.
service.